it's really, really great to see your faces again. And I hope you all enjoyed that holiday that we had that no one can probably remember now because it's been so long ago. That was Labor Day weekend when we took off for Facts and Faith Fridays. But for our first session back in I could think of any more fitting speakers to have today other than Dr. Christa-Marie Singleton from CDC. She's a seasoned Facts and Faith Friday saint. And Dr. Elaine Perry, who's the new health director for the Richmond and Henrico health districts. For those of you who did not know, that vacancy has now been filled. We're hopeful that Dr. Singleton and Dr. Perry will help us better understand where things currently stand with COVID. Is it a pandemic? Is it endemic? What is it? And what do we need to know about the Omicron vaccine booster? And I think people are still really concerned about monkeypox. So we have a lot to cover. We hope they will share whatever else is on their hearts today. And with that, before going too far, I'd like to ask Reverend Ponder if he wouldn't mind opening us up in prayer.
I sure will. Let's pray together. Eternal God, we thank you again for this opportunity to gather with Facts and Faith, and that we might be more faithful in serving our community, educating and inspiring, encouraging, that we might be whole and well. Bless our presenters today. Bless those who are responsible for organizing our gatherings. And bless us, dear God, that we might receive information that will be helpful in moving forward. We offer this prayer in the precious and powerful name of our Lord. Amen and amen.
Amen. Thank you, Reverend Ponder, for that beautiful prayer. So next I'll turn it over to Dr. Winn, who will introduce Dr. Singleton as well as provide, I think, some general local updates about what's going on with COVID.
Here's what I will make an announcement of. I'm going to say to you all that I am here in Philadelphia, Pennsylvania at the moment. And one of the things that has been circling the area, interesting enough, even at an AACR meeting, which is around cancer, is how have we been getting the message out about COVID and about cancer screening? And many people here at this conference are asking and wanting to know more about Facts, Faith, and Friday. In fact, did not know, but when we were having these things and holding them weekly, it turns out that we actually had a group from New York in Philadelphia, from all places in Detroit, that were consistently joining in on the weekly basis, trying to understand what it was and what we were talking about and taking notes about the types of information we were giving to the community. So again, I'll say hats off to you all. And in fact, I'm not going to talk too much because we have, both the two hottest tickets in town, Dr. Perry and Dr. Christa-Marie Singleton, from the CDC. So I don't want to take up too much more time other than to say that I'm going to turn this back over to you, Sister Rudene, and then we're going to go from here and get some real good information.
Awesome. Dr. Singleton needs no introduction. She's been with us at the beginning of the pandemic, while we were all suffering through it, while we were suffering through the vaccine, while we're still kind of in a pandemic, not quite certain, but I'll turn it over to you, Dr. Singleton, to give your presentation. And I hope that folks will either pass along comments or questions in the chat, or will, provide their questions live when the time comes.
Thank you for the honor of being back when I feel like I'm back home. I was teasing Sister Rudene. I'm like, y'all don't like me no more. I haven't been asked to come back, nothing. I've been eavesdropping on a few talks, but it's all good. But thank you for the opportunity to be here and talk with you and share some just high level comments about monkeypox and where we are with COVID. And my colleague, Dr. Perry, is going to give you like the local flavor, because all politics, all disease is really local. And so I welcome the partnership with her. But so let's talk about this thing called monkeypox. And so it is what we call an orthopox virus. So basically, it's a cousin of smallpox, but it's a milder disease. I am barely old enough to remember a little bit about smallpox. I got the little mark on my arm, I guess as a child, but didn't know anything about it, but had the opportunity in my early public health career during one of the wars. I don't know, it wasn't Desert Storm, but in any case, when there was the Iraq invasion and smallpox was perceived to be a potential weapons of mass destruction. And so we at the local health department level in Baltimore had to vaccinate people against smallpox. So it's similar to that concept. And it was formerly found in West Africa, and it started spreading again in 2022. And that's what made people kind of scratch their heads a little bit, like, what is this and why is it back? But it is a milder disease than the smallpox from back in the day. It historically shows up as a flu-like symptom, and then you get this rash. And so the rashes progress to sores, blisters, and scabs, and patients are ill for about 2 to 4 weeks. And most people recover without treatment. There are some new treatments that are out there. And in a global outbreak, the flu-like symptoms are often missing or mild. And so if you see some of these pictures here, you get these blister-looking things. They look a little bit like, once they start out like little mosquito bites, but there's a white base, and then they turn into this kind of blistery-looking scab thing, and then the scab crusts over, and it's done. But how do you get it? Well, this current outbreak is coming from close skin-to-skin contact with someone who's got a rash or scabs from monkeypox. So the key, where it's seeming to show up right now is with, and anyone can get it. Is really showing up more in communities where men who have sex with men or multiple partners, but anyone can get it, and it's coming from, again, those skin rashes and that contact. What we have been seeing is that it's been coming through sexual contact. Is not a sexually transmitted disease, but if you're in that kind of, activity, the bodies are close together. And so that's where someone who has a rash that's not known, and then they're in contact with each other, and then that's how it spreads. It can also include contact from, spit droplets, or if you break open one of these rashes and you didn't realize you have the rash and it's on a surface or a toy that's been used by someone who's got monkeypox, it can spread that way. So basically following the do's and don'ts to prevent getting monkeypox, it's always kind of like the back to the basics: washing hands and using an alcohol-based hand sanitizer, but talking with your healthcare provider about your risk of getting monkeypox and getting access to available vaccines. In communities where we have seen it showing up more, particularly communities where there's men who have sex with men, and some of these communities like that, that's where some of the vaccine efforts have been more focused. And so if you have family members, church members who may be part of these communities, and you may want to encourage them to talk to their provider about, hey, can I get one of these vaccines? Key things: don't have close skin-to-skin contact with people that have this rash that might look like that. And I showed some of the pictures earlier. Touch the rash; it is itchy, and you don't want to keep from scratching it. Sharing utensils or someone who's got monkeypox, or touching the bedding or clothing of someone who's got it. But what do you think you should do if you think you might have this? You've got a fever and your swollen glands and you're starting to see a rash. Well, first of all, see your healthcare provider or your public health clinic, and Dr. Perry is going to talk about some of the local actions you could do there. Cover the rash. If you see this rash starting, some kind of rash, will cover the rash with clothing or gauze, something to protect against the spread, and wear a mask. And try to avoid touching anyone until you've been to the doctor or healthcare provider. Don't scratch them. It doesn't speed up the recovery. Don't shave at it. Again, it's that hand washing with the alcohol sanitizer. If you've got the rash, you can cover it with gloves, and then dispose of those gloves. Managing symptoms, because it does sometimes come with the flu-like illness first. So Tylenol, Motrin. If a lot of times people are getting these rashes around the mouth area, and so you can use like the mouthwashes that have a little bit of lidocaine, or to kind of keep your mouth clean. But again, the healthcare providers will help you. The biggest thing is not to touch that itchy rash. It's tough, but gels and creams like Benadryl can help protect against it, or soaking in oatmeal baths. And if you happen to be a person that has monkeypox, try to avoid being around small children or people that might have immunosuppression illnesses. But a key question that this group might want to think about, or might be thinking about, what about people going to crowded events? And because some of the activities right now to really put focus on monkeypox and where it has spread has come from some of these large events where there's a lot of skin to skin contact. And so that might be of concern. And so if you want us holding an event and planning to attend an event, consider how much of that skin to skin contact is happening there. So if your perhaps faith community, if you, the way you practice and worship, is in an area of high transmission and there's a lot of skin to skin contact to pay you how you practice, that's the case where we're talking with the local health department officials to say, what else can we do and plan for these events? The CDC guidance on our pages that talks about crowded events is really more talking about like these dance parties, these raves, that sort of thing. We don't have a specific site that talks about large gatherings like a church gathering, but I'm also very aware that we all practice our faith in different ways. And so that's just looking at like your community, looking to see what's there, thinking about how you practice, and then maybe making some recommendations to individuals who worship with you is to make them aware this could be in the community. Now, where can you go get tested to monkeypox and when should you get tested? And it's really only recommended if you have a rash that's consistent with it. And again, Dr. Perry is going to talk about the local options in the Richmond area so that you can get the treatment that you need. Again, we talked about vaccinations. So you may want to get vaccinated if you have been identified as a close contact with monkeypox. This is not one where you necessarily need to go out and get the shot just because you're interested into it, but it's more of you're either a close contact, you've had a sexual partner in the last 2 weeks that had monkeypox, you are in a situation where you've got multiple partners, or you're in an area where monkeypox transmission is occurring and you're engaging in some of these types of behaviors, or you might be a transgender or gender diverse person who's been in that kind of setting. So that's really where the vaccine is most focused on being given. Now, what about kids? Because every state in the country right now has had at least one case of monkeypox in someone, and there have been cases in children. And children don't usually fall in the children having sex with children piece of it. So the risk of monkeypox to children in the United States is really, really low. But there have been some cases. And so those cases have most likely come from being in contact with an adult who had monkeypox, probably didn't realize it. The clothing, the bedding, the toys got infected, and then the child touched the toys. And so schools and childcare settings, the biggest thing for them is just keep following their everyday disease prevention routine, encouraging staff and children to stay home when they're sick, having access to hand washing supplies, and cleaning, disinfecting like they've been doing. And if there's a child that comes to school or daycare, or maybe comes to their, let's say your church daycare, have a private space so you can look at the child and see what's going on with them. And if they've got a rash that's consistent, like with these bumps, they might need to go home and cover the rash with gauze and talk with their doctor to try to get them into a healthcare setting. Now, someone might ask, well, I've got this, big event, church event, and I've had somebody with monkeypox that we've heard of, and we want to welcome them back. And when can they come back? So the monkeypox causes a rash with these scabs that come, these lesions that come over, and they will eventually scab over. And so what you want to do is prioritize those individuals to isolate themselves until all the scabs have fallen off and a fresh layer of healthy skin is formed over. It might take as long as 4 weeks for that to happen. And caregivers of individuals should work with the healthcare provider and the health department to see when they can come back to either school or work. But it's usually the biggest thing is those scabs have got to heal over before they come back to service, before they come back to school, before they come back to work. And hopefully people are taking that seriously. All right, I'm going to switch gears to our friend, Mr. COVID. And it's that at the current talk, we still are living with COVID. I was sharing with Sister Rudene that I spent my summer traveling with my 16-year-old son, and both of us came home with a little souvenir of COVID in that pace of it. He got it in Birmingham, and I got it in Boston. So the current variant is quite active. And so now there is a updated booster that it's got a little bit of the old school and a little bit of the new school. So it's focusing on this new variant that has dipped and dapped and gotten around us. And luckily with the current variant, it's seeming to be not as severe disease, but it's still no fun. Like I said, my personal experience was luckily my symptoms were mild, more sore throat than anything else, but I was not happy. And I, took it seriously. As soon as I felt bad, I took a rapid test, showed it. We were just coming back from Boston. I showed my family. I'm like, you got ding, ding. And I'm like already starting to move into the bedroom. I'm like, that's it, we're in. And so I was in there and I isolated myself and then started testing myself to make sure I was negative before I came out. But who should get it? Everybody who's up 12 and older. The new boosters are available. There is a Pfizer version. So if you're Team Pfizer, you can get Pfizer. There's Team Moderna. You can get Team Moderna. And so those are available and you don't have to, you can mix and match of those two. People are asking, what about children? So if kids 12 and older can get a booster, and what we consider up to date for COVID vaccination is that you've had your primary series and then the new boost and a booster. So all the boosters that are available. The youngsters before were just, I think when the last time I talked to you all, the youngsters meaning 6 and up, they're 6 to 5 had not gotten approval. Well, now we have one for those young kids, and it supports, our data shows that it's just as safe as it is on the adults and we got. We're not seeing as many of our babies and youngsters getting vaccinated. And so I encourage you to encourage your communities. The best way to protect these littles is to get them to go ahead and get their shots. We are coming into fall season, flu season, vaccine season. And so we as adults need to get our boosters, and the little ones need to get their boosters as well, and your flu shot. So there's that. So Dr. Winn asked me to talk about the current updated guidance if you test positive. So I was sharing my experience of testing positive. So when I have tested positive on the July 31st, I started to feel sick, tested myself, boom, you're positive. That's day 0. And so I went to my room, kicked everybody out, wore my mask, and if I ever had to stick my head out the door, and I stayed away from everybody else. And you heard me talk about my 87-year-old mom, because she's at high risk for severe illness. I didn't go see her. And I wanted to go through my whole period of time. So I stayed home and away from people's, and which is what we recommend. And then by day 5, I stayed home for 5 days. I stayed in that room for 5 days. On day 6, I tested myself, and I could have ended my isolation, and I did. I actually came out of the bedroom and then was walking around the house. But when I walked around the house, I kept a mask on. And the reason I walked around the house and ended my isolation in my bedroom on day 6, my symptoms, which were sore throat, had gone by day 3. So if you don't have symptoms, or you're fever-free for 24 hours and your other symptoms have improved, on day 6, you can leave your isolation space. We still recommend that you wear a mask through day 10, or you can start taking your home test to make sure to stop wearing the mask. But the biggest thing is stay isolation for 5 days. Day 6, you can exit if your fever has gone or your symptoms have improved, but you still need to wear a mask through day 10. And ideally, you can either stay with the mask through day 10 and be done with it, or if you're tired of wearing your mask, then you can take your rapid test, but you need to have 2 of those to make sure that they're both negative, and then stop wearing the mask. In that same period, you should always avoid people that are at high risk for being sick. So like in my case, I waited until those 2 tests were negative before I set foot over my mom's house, because she's high risk of being sick. And so I didn't want to run the risk. And we did the same practice with her caregiver, who just tested positive 12 days ago, but we waited until she had those 2 negative tests to come through. So bottom line is, your test is your first day of being sick and getting your rapid test or PCR test is day 0. 5 days, stay isolation. Day 6, if you're feeling better, you can leave isolation, but wear a mask. Stop wearing your mask at either day 10 or 2 negative tests. All right, this thing with the boosters I talked about. So I'm coming to the end here. If you are 6 months old through 4 years, you should get their primary series doses. So the littles can get the Pfizer's, and then the people, the babies 5 years to 11 years can get the original booster. 12 years and older, they can get the new booster, which is the little bit of old and a little bit of new. And so only the kids 12 to 17 can get the new and improved one. The kids 5 to 11 right now can only get the original 5 Pfizer boosters. So there's 2 Pfizer boosters for people under 12. I mean, there's 2 Pfizer boosters. If you're 5 to 11, you got to get the original booster, which will bring you up to speed. If you're 12 and older, we recommend that you get the new and improved one with the little bit of old and a little bit of new. And then here's a really cool site. And so I will drop this in the chat as well. If you're wondering, well, when should I get my booster? I had one in the spring. Should I get another one now? Or in a case like, well, I had my booster and I ended up getting a breakthrough case. Do I still need a booster? And so this website's really cool. This little, it's a little calculator, and it tells you when to get your booster. It'll ask you how old you are. It'll ask you, have you had COVID? It'll ask you when you had your last booster, and it'll tell you, it's a nice little calculator in like 2 seconds on your phone to tell you when to get to do that. So like in my case, in my son's case, we are waiting to get our next booster when we've had 3 months out of the COVID vaccination. My husband has not had a booster since last year, so he's getting in here. We plugged him in as well, but I'll drop this in the chat. And this is a great site in case anybody's interested on when should I get it or how should I get it. It's really cool there. And with that, I will turn it over to Dr. Perry.
Well, before Dr. Perry starts, thank you so much, Dr. Singleton. I do have a couple questions. One has to do with masks in churches. A number of our pastors and preachers are continuing to require people to wear masks in their congregations. What are your thoughts about that? Because I think some people are getting tired of the mask, and they weren't anti-maskers to begin with. So just a question there.
Yeah, it's one of the things we recommend for COVID protection is like a layering of support. And if you're in a community where there's a high transmission rate, that extra mask is an extra layer of protection. It's not required though. And so if those pastors really feel strongly about it, then that's their preference to do so. But it's not necessarily required. It's more of just an extra layer of protection.
Okay, and then one last question about monkeypox. Thank you for being so detailed in your description of what it looks like, what we should be concerned about. But I'm not really hearing a high number of cases of monkeypox, and I worry that people are going to be lulled into thinking, oh, this isn't really as big a deal as COVID. What are your thoughts about, I guess, the rate of increase with respect to the monkeypox cases? And we know it's not a pandemic yet, but should we be concerned?
Well, the cases actually have, monkeypox has been something that's not really that big of case numbers. And then we had the spike that popped up earlier this year. And that's when the World Health Organization said, oh, this is a public health emergency, because it was a lot more than the baseline. And those numbers have gone up. And Dr. Perry's going to have the more local numbers for Richmond. And then it's coming down. So I wouldn't say it's a case of being lulled in saying it's not a big of a deal. Where I personally am concerned, and I think where our agency is concerned, is that it, like many other chronic diseases, seems to disproportionately affect our Black and brown communities. And they may not be getting the information about this is still out here, and it is something of concern, particularly if you are in right now, the illness seems to be most affecting certain communities. So if you happen to be one of those communities where you're engaged in these sexual behaviors, some of these teenage communities where, these teenagers are the college students, skin to skin parties and all that sort of stuff, then these are considerations you might want to make. So I think it's an important one for teenagers in certain communities, in particular our Black and brown communities that aren't as active with their access to healthcare. I think they need to continually be aware that this is something that can affect them.
So, quick question. This is going back to the booster. The old booster versus the new booster. Is it that the old booster wasn't that great, which is why people got breakthrough? So that's why we got a new booster. Is it going to prevent breakthrough? This is what's on the minds of people.
Yeah. No, I think the old booster was good, and it's still good. And that's, for our youngers, that's what's out there. I just think it's, Omicron was just a sneaky little one and got around folk. Because remember, the vaccines were made to keep people from serious illness and death. And that's what they have done. The vaccinations have prevented the numbers of people that were in the hospitals, on the ventilators, the death rates, even though unfortunately people are still dying, but it's not as high as it was before. So the vaccines have done their job of keeping people out. It's just that they are high level. We talked about that raincoat. It's like the raincoat kind of slipped a little bit in terms, so it ducked in and got you. And so you still got through, you still got wet, you just didn't get soaked. And so now the Omicron vaccine number 2, hopefully this time is more targeted to say, okay, I see you coming for me, so I got you.
So Dr. Singleton, again, just to clarify for some on the call who've had multiple boosters, right? Even so, you need to get the Omicron booster.
Right. Yeah. Somebody said, I've had both boosters. Does that mean a third booster? Yeah, because if it depends on when you got it depends on when you got your booster. So like if you got early on, I'm trying to think, like I got my booster. I got the first one almost Thanksgiving of last year because I thought I was going to be traveling. Then I got my second one in May, right before I was traveling to that certain place in South Bend, Indiana. And so I got it 2 weeks before I went to that trip. And I was kind of like, it's showing it your immunity and your protective antibodies. They're kind of highest like 2 weeks or 3 weeks right after. And I knew I was going to be with a bunch of crazy folk up in South Bend, Indiana at the wonderful University of Notre Dame. And I wanted to be protected up. And so I got it there. But then over the summer, it has kind of maybe have waned. And so that's probably why I got the sneak attack and got sick in August. So yeah, I'm going to get my 5th booster, my 5th shot, but I'm going to wait until probably closer to November because that way the protection I got from being sick will have waned off. So
yep.
Oh, that's funny. Chuck has said you're right on the number of shots. It will be your 5th. He's already gotten his 5th shot according to the chat.
Yeah.
One last question though. So with our cancer patients or people who are immunocompromised, we know, for example, with prostate cancer who are actively getting therapy, we know about boosters and things, but could you talk a little bit about the things that are available for them? For example, the AstraZeneca drug that may be available, or what's the advice for immunocompromised folk who, for example, are cancer patients getting active therapy, like, for example, back in the day, Colin Powell?
Right. And so those individuals, there are treatments, was Evusheld, and there may be a couple other monoclonal antibodies. So those individuals that are immunocompromised, immunosuppressed, they don't mount as much of an immune response as someone who doesn't have that condition. So you'll get the shot, and let's say if a person like me who's not immunocompromised and I get a shot and my protection levels jumps to 100, and 100 is considered normal. A person who's immunocompromised, immunosuppressed, they may only get to like 40. So like, so if I had a shot, I'm getting some protection, but I need a little top off. So that's why those individuals can get additional antibodies through AstraZeneca medications, one and the Evusheld, Glaxo. There's others out there, so they should get those extra antibodies in addition to their boosters to help protect them and give them that extra layer.
Thank you.
Thank you so much, Dr. Singleton. Now, again, I know people have tons of questions, but we want you'll have the opportunity to hear from Dr. Elaine Perry. we're going to turn it over to another seasoned Facts and Faith Friday Saint, and that's Amy Popovich, who has been with us again from the beginning. She's helped manage sort of the COVID, in our area and encourage vaccinations, and just probably one of the most positive people I've ever met at the VDH. So Amy's going to introduce Dr. Perry, and again, happy to have both of you all here.
Shout out.
Hey, everybody. Great to be back with you all again. Thanks for the kind words, Dr. Winn and Rudene. Yeah, feels like we're family on this call. We've made it through a pandemic together, and I'm really grateful. And I'm also grateful that we have more support on our team and a new leader in Dr. Elaine Perry. So she'll tell her a little bit about herself when she joins, but has been a health director before, comes to us as a seasoned professional, public health professional. And I'm excited that she'll get to talk about our monkeypox response. I think we've learned a lot in COVID, and we were glad to be able to apply it to another communicable disease that has a vaccine already from the get-go. So we were able to vaccinate our first person within 24 hours of having our first case here. So it feels, of course, not good to have another communicable disease spreading in our communities, but really great to feel like we can provide the public health response that we want to when these scenarios arise. So with no more further ado, I will introduce Dr. Elaine Perry, the new health director of Richmond Henrico Health District. Take it away, Dr. Perry.
Thank you so much, Amy. And yes, I am so happy to be here. I'm just a little over 2 months on the job here with the amazing team at Richmond Henrico Health District, including Amy and others. They have made my job coming in here so much easier. I say it's so much easier to step into some place where you already have a high performing team. But yes, I have been in local public health in different parts of Virginia over the years, out in the Shenandoah Valley, up in Northern Virginia, in Loudoun County. And then years and years ago, I was down in Peninsula as their health director down in Newport News and that parts of the peninsula. So, but very glad. I keep coming back to local public health. Local public health keeps pulling me back in, and just so happy to be here in this community and part of this conversation this afternoon. So I'll just talk briefly, give some local data, like we talked about, some local perspective on, I'll start with monkeypox first, following Dr. Singleton's lead. So what we have so far in Virginia, there have been 425 cases of monkeypox, 19 hospitalizations, and fortunately at this point, no deaths. Now, the number of new cases each week in Virginia has been decreasing in the past month or so, again, as we're seeing in other parts of the country. And so, we are very optimistic about this, but I would say cautiously optimistic, right? We do not want to take monkeypox for granted in any way, shape, or form. And so really continuing on the good public health that we're doing here that I'll talk more about in a minute. As with other places in Virginia, 96% of the cases are among men, which we're seeing in other places. And in terms of the most impacted racial and ethnic groups, again, and these are for the cases that we have information on across the state of Virginia. So far, there's been 40% reported among Black individuals, 25% white, and 17% who identify as Latino or Latina. So in terms of our response here locally, Amy already said, it's horrible to have another infectious disease to manage. It is nice when that one already has a vaccine associated with it. And so we had a very high demand for vaccine initially in the area and a very limited supply. And so what we did was we developed an online vaccine interest form. And so we knew that not everybody who wanted to get a vaccine really needed to be vaccinated. FDA and CDC, very thoughtful, very considered risk categories, people who are highest risk. And whenever in public health we have a lot of interest, a little bit of something, whether it's a vaccine or medicine, we really try to do risk categorization, risk strategy, and who needs the vaccine most. And so we did put that vaccine interest form out, widely publicized it in the area. So people were able to go online, fill out some questions. Some of these questions were tricky questions. We did ask difficult questions, but again, it was trying to get to who really is at the most risk because of what is happening in their life, the potential for exposure. We want to vaccinate people who there was a greater chance that they were actually getting exposed to the monkeypox virus. So we put that vaccine interest form out very, very early on, and got many, many responses, over 4,000. We may even be over 5,000 responses at this point of people who expressed interest. Not all of them met the criteria. right? And so we've been working through them based on, again, risk categorization strategy, those at highest risk of exposure, and then moving down the risk. Our highest priority has always been people who are actually exposed to someone with monkeypox. So that post-exposure, somebody who is a known contact, we wanted to get to, and do get to those folks first still today. But again, lower risks, gradually getting to people as we work through the form. Fortunately, along with the slowing down in the number of cases, we are seeing less interest in this vaccine interest form. For example, we were getting 100 to 300 new forms a day. Now we're maybe 30 or fewer every day. We are actually starting to see more people not show up for their appointments at our vaccine clinic, which means we overbook, right? Like we know that some people aren't going to make it, and so we overbook. A lot of reasons for that. It could be that people are getting their vaccines elsewhere. It could be for whatever reason their risk circumstances have changed. So, but again, we're definitely seeing less demand, and so we're getting to the point where we feel better that we're getting more caught up with the supply. One thing I didn't mention earlier, and I do think is really important to call out though as well, is that we didn't just rely on the vaccine interest form. I mean, as we know, anything that you're doing online, there are people who have limitations to technology, be either because of access to it or just comfort level with it. And we really wanted to make sure that we were reaching out to those populations who were most at risk of actually coming in contact with the virus. And so we did have some of our staff here. We have some great staff who routinely work with the LGBTQ community in Richmond, reaching out. So in-person outreach, working with community partners, word on the street, word of mouth, getting information out about this. And so for people who were sort of hesitant to fill out the form themselves, we could get that information. And again, if depending on their risk, get them in to be vaccinated. And just generally increasing awareness and education about the virus, what it meant, what to look for. And so that was a really important part. So we had the tech solution and we had the low tech solution, right? And I think both of those have played a key role in our, increasing awareness and access for vaccination in Richmond and Henrico. So far we have administered a little over 1,400 vaccines to people here. We also are in a position finally, which is great because this wasn't the situation at first. We are actually able to redistribute or share some of these vaccines with other community providers. Amy talks about lessons learned in COVID-19. We learned very early on, when you're the only game in town, it does not go well. And so we really have been very glad to be able to share the vaccine with other folks in the community, healthcare professionals, again, who are working with the populations most at risk. They may not feel comfortable going to the health department, right? They don't want to come to our building here on Carey Street, right? But they may be more comfortable going to their own provider, someone else that they have a greater trusted relationship with. And so we've been able to do that. And really our plan on expanding that. It's something we did locally. We're getting more support from our central office, at the state level, to do some more of that sharing of vaccines as well, because that's so important. Again, trying to reach people where they are. The more convenient you make it for people, as again, learning from COVID, the more likely they are to get vaccinated. So overall, at this point, we're at a little over 1,700 vaccines being given to people, in Richmond and Henrico between us and our community partners. So we still have a supply. We have switched very recently from, and this was definitely a federal, from the FDA and CDC recommendation to do so. So when we started out, we had one vial, was one dose, right? So you take a vial, traditional vaccine, go ahead, give it right underneath, subcutaneously, so under the skin, but deeper, right? Like you would get, for flu shots or a lot of other vaccines. Then some additional work was done to look and see, well, we can stretch these doses by giving just a smaller amount right under the skin. For any of you who've gotten a TB test, a Ppd test is that same kind of thing. So small needle, a little bit, just goes right under the skin, a little, blood pops up. And so by doing that, we're able to expand the number of doses available to us. And so we have been doing that, as other people in the state have. So that expands our supply and increases the access to people with, for vaccines. We are continuing to get vaccines from the state, from the CDC through the state. And so obviously continuing that very important work. In terms of additional outreach, again, I mentioned we have people who are already working with some of the communities at greatest risk. continuing to work on outreach, education, awareness. We've done some town halls with healthcare professionals to educate them as well, right? What to look for. You know, if you have somebody coming in for a rash, this is what to look for. This is what to do in terms of testing. These are the options for treatment, right? Because again, you know, at the health department, we really are, you know, we use the term safety net, right? I don't like to use the term healthcare of last resort because I don't like to think of us in that way, but sometimes we really are. But it's still, the message is still, if someone is in, has a trusted relationship with their own healthcare professional, let's get those healthcare professionals educated, aware, so that people are comfortable, right? They're going and they're getting evaluated by someone they know. If they can, they're getting their vaccines by somebody that they know, right? Just really building on that principle of you know, primary care, healthcare homes, really trying to do that as best we can. And so working with our healthcare professionals to do that so that people have more access to care and potentially more comfortable access to care as well. So, you know, as Dr. Singleton mentioned, we do have testing is available. It's got to be symptomatic, right? So somebody can't just come in like we were swabbing people for COVID left and right? You can't do that. It is a swab, but you've got to swab a lesion. You got to swab the rash. And so really it's only for people who have those symptoms. Again, it is definitely available, you know, urgent care centers, emergency rooms, primary care, really trying to encourage them to do that. We do have some limited testing available here at the health department alongside of our sexually transmitted infections clinic. But really, if people can, we do encourage them to reach out to the healthcare professionals that they know and trust to be evaluated. And so in terms of interest of people who do think that they may be at greater risk and do want to get vaccinated, there is our website, which is rhhd.gov/monkeypoxvax. And I can pop that in the chat later, or a phone number. People can just give us a call at the health department, 804-205-3501. Obviously, again, as previously shown, the CDC website has a lot of good information, and it's tailored to different levels. There's information for healthcare professionals, there's information for the public, and everybody in between. And so we think that that's really important. The other thing that's important to mention, as previously alluded to, communication is key all the way around in public health, right? So communication with the health department and folks in public health to the communities, communication between patients and their healthcare professionals, and communication between sexual partners, right? So if someone has a rash or starting to develop a rash and they have concerns, having those open discussions with their sexual partners to say, look, you know, this is going on, and obviously taking appropriate precautions at that point. So really trying to help, you know, reduce the spread of this, because we don't want this to be, you know, another COVID, right? We don't want this to be another pandemic. We definitely take it seriously, but we don't want to get into that situation again with monkeypox, or as we did with COVID. So really, and I neglected to mention our numbers. So right now we've had 27 cases of monkeypox in the city of Richmond and 15 in the county of Henrico. And, you know, again, so more than some of the other areas, but not as much. For example, Northern Virginia was hit pretty hard, particularly at the beginning. So we're seeing less of it than in Northern Virginia, but definitely more than in some of our rural areas. We do still have some rural areas that have not had any cases yet, or at least not cases that have been detected. And so that's where it's important, obviously, that testing and treatment, particularly testing. All right, so now switching gears to COVID-19 here quickly. So again, as previously alluded to, we're looking at community levels, high, medium, and low in terms of deciding what people can do or give the guidance that we give. At this point, Richmond City and Henrico are both at a medium risk level. Henrico's been there for a few more weeks. Richmond City just got there a couple weeks ago. So we're keeping an eye on it. It is way too soon to declare victory, right? So the virus is still in our community. There's still people getting sick. There's still people being hospitalized. And, you know, people are still dying from this virus. And so we really don't want people to let their guard down. It is so important to encourage folks to go ahead and get that bivalent booster. You know, as long as you, again, Dr. Singleton mentioned, as long as you're 2 months away from your last COVID-19 shot, go ahead and get that. It's going to expand the protection. It's going to help protect you against this Omicron variant that is just running rampant through our community and others. And so it really is very important to encourage folks to get that. when they're ready for it. And love that CDC website that does the math for you. It makes it so much easier, right? Very quickly, case numbers for COVID-19 right now in Richmond, we're at 170 cases per 100,000, 131 per 100,000 in Henrico. Across the state of Virginia, we're at 146, just for reference. Hospitalization rate in Richmond and Henrico is about 13 per 100,000. And as of now, our vaccination rates, they're a little bit higher in Henrico. Fully vaccinated is running about 71%, a little bit lower in Richmond, a little under 59%, and about 72% across the state. So I know I went through that quickly, but I really am looking at the clock here, and I want to make sure that we have more time for some great questions for everybody. So I'm going to go ahead and pop our monkeypox website and phone number in the chat, and then definitely open to more questions for both of us.
I think Amy jumped to it.
She did?
Yes, Amy.
Good. Thank you. All right. I was looking through my notes. I didn't have to think. See, this, like you said, you come into a place with a high performing team, your job.
Exactly.
So.
They do the work for you.
Thank you.
No, Dr. Perry, thank you so much for your very thoughtful sort of laying the land for us for what's going on locally. I guess there are a couple of questions in the chat. One is, where can we find the current positivity rate for the week? I think some of the numbers that you quoted was from the dashboard, I think, for the VDH, but can you, would you or Amy sort of put in the chat again where we can find the positivity rate for the week or the month or whatever?
So you're talking about, for monkeypox or for COVID or for both, right?
I'm sorry, I was thinking about for COVID. I didn't really think about the fact that there could be a equivalent concept for monkeypox, but that makes sense. Would you mind sharing that?
So from the state perspective, Virginia Department of Health is now publishing a monkeypox dashboard as well. And so you can see the counts for the state, for their regions, and then for each individual district is. So for example, we are the Richmond City Health District and the Henrico County Health District. We just are together in terms of shared leadership. And then yes, so Amy is popping the numbers in as well, because you can go through the state. But then the other thing that the CDC has done, which is so nice, is again talking about these community levels, like really getting to that. Instead of focus on an exact number and 89.7, it's what's the level, high, medium, or low. Just tell me that. But there are still numbers behind that, right? It's the numbers that drive that level. And so the CDC has a community level webpage where you can go, and again, for any political, whether it's county or city, looking at state, you can go and see, okay, for my city and county, this is what the numbers are in terms of cases, hospitalizations, and hospitalization burden, and then what the level is for the, yes, thank you, Amy, so that you can see what the numbers are. And those are updated weekly. Monkeypox numbers, I think we're still updating daily, I believe, at the state level, right? We're to try and keep those up to date. But for COVID, those community levels change on a weekly basis. They usually get posted Thursday afternoon to Thursday evening, if you want to see what your level is for the week.
Gotcha. Let me ask you a question. So, during the push to get people vaccinated, there were opportunities for there to be pop-ups for community vaccines, for COVID vaccines. I know we have limited supply of the vaccine for monkeypox, but do you envision it? Will there ever be an opportunity for perhaps churches or local community groups to host pop-up monkeypox vaccine?
Well, I'm glad you asked that question, because actually just last weekend, there was the local health department staff here did do an event with diversity, where over 236, I may get the number wrong, Amy may know the number off the top of her head, vaccines were given. Now, to be fair, these are still by appointment only, right? But we were able to go out, give them, sharing space with a community organization, again, trying to get closer to where people are. So it still is appointment only, because again, just because we are still really trying to make sure we're getting people at the highest risk first. But stay tuned. We'll see, if demand decreases, supply stays steady, we may be able to expand that model. The other thing we want to be careful about is that there is talk that eligibility may expand, right? So the CDC, FDA may say, all right, well, these are the people we said are eligible now, let's expand that. And if we do that, increase demand, we don't want to get to a situation then again where we're trying to catch up. And so for now, we are keeping it an appointment only model. But again, like this past weekend, appointment only, but going out and doing vaccinations in the community. We definitely want to continue to do more with that. Again, working with our community partners in terms of, getting vaccines. So we're not the only game in town to get vaccinated, but then definitely keeping an eye on the numbers of both cases, demand, and supply to see if in the future we may be able to do something like, again, a small event at a church, at another community organization, trying to make it easier for people to access those vaccines as this continues to unfold.
And the one thing I say,
236. Okay.
Yeah, I know. Amy's again amazing. The other thing to think about too is in doing these pop-ups, sometimes it's not the real value is not just getting the number of vaccines administered. It's like raising awareness in that community. So if you see one of our churches sort of host one of these events, it's at least getting people thinking and talking about this is a thing that we need to be concerned about. So yeah, keep this group posted because we'd love to be able to work with you on that.
And Sister Rudene, I was just going to comment that it's also important to know that the 3 C's are traveling together, and it would be either Dr. Perry or Dr. Singleton. How I know that the focus has been on the communicable diseases in the context of infectious diseases of COVID and obviously monkeypox. But as we're moving through this, we know that there are cardiovascular disease issues that have not been addressed as a result of things in COVID. We also know that there were cancer issues and screenings and other things that have not been addressed through this issue of COVID. How is either locally or how are we thinking at the CDC level about knowing that I am looking as a clinician, looking at that next tsunami that after we get through monkeypox and COVID, what's right ahead of me. So are there any thoughts about what the CDC or locally, what are we preparing to sort of address those issues that are literally feel like they're around the corner?
Well, I'll start. We are looking at, in fact, a project that I'm very, very proud of that I helped get funded is looking at building up the capacity of, it was originally intended as for providers of minority communities, serving minority communities. And then it was more expanded to if you're serving a minority community, but to look at just that issue. COVID was the initial kind of bait to get people in, but then of course, recognizing that getting a COVID shot is probably not on the high radar of some of these other chronic conditions. And so these communities are looking at how do we screen for people's social needs in the context of COVID, getting them access to care or care that's been neglected. So at least there are sections of us that are thinking about it because, and I would offer that what Sister Rudene was talking about, using maybe the church as an opportunity to give out information about monkeypox and talk about, hey, by the way, when's the last time you had your blood pressure checked? Hey, when's the last time you had whatever done? I am participating in a mass COVID vaccination event here in Atlanta next Saturday. And I suspect because every other one, the CEO of DeKalb County, he brings in, it's like a one-stop shop. It's in the south side of DeKalb County in pretty much the Black and brown area. And so he will have with people there, he's going to have food stamps, he's going to have all that stuff in one spot. So you just kind of roll through and get a little bit of everything. And it's like, when's the last time you had your all those screens that you probably missed out on, it's there at the same time to talk about health and wellness at one spot. And he's giving out, I think he's giving out green lollipops, if I believe correctly.
Now that's gonna get them.
It always does. He gives out, 100, these green lollipops that have a little, Benjamin on the front of them. And they gives them out, and people start showing up for that spot. So just so you know.
So that's the trick. We need to get some green lollipops. No. And I mean, I completely agree with you know, both Dr. Winn and Dr. Singleton. It definitely is an issue, you know, we are concerned about here as well. I will be honest with you, at the health department, I do still feel like we're kind of doing a lot of this in terms of just let's you know, tread water and keep through you know, getting through COVID-19 and now monkeypox. However, you know, understand that public health, local public health is so much more than that. You know, continuing to address and invest in our broader population health efforts, having our community resource centers that are out and about at various locations throughout the city, you know, making sure that the folks there are very strong community health worker program. They are able to address some of these more chronic conditions. They are the ones to ask that question. When was the last time you had your blood pressure checked? Yes, you're coming in to ask me about X, but what about Y? And so, you know that that's something that we really are, you know, aware of and concerned about. And we've got to not let that become, I love that image, you're the next tsunami, right? Of all these chronic diseases that people just have not managed because they've been, well, for a variety of reasons, right? Whether they've been afraid to go to their doctor or just haven't had the time to do that, haven't had the access. And we know that cancer we haven't cured cancer, we haven't cured cardiac disease in the past 3 years. And so it's definitely something we want to keep our attention on and action toward.
Well, Dr. Singleton and Dr. Perry, again, and Amy, I thank you all for being on the call today. I would like to just ask our attendees just to give us a couple of minutes to run through a few announcements. First of all, a huge thanks to the Richmond City Council, and in particular, Councilman Pastor Michael Jones. So if you get a chance to see him, tell him thank you for being instrumental in recognizing the work of the Facts and Faith Fridays initiative. The initiative won the Community Service Award, and that's in large part to all the great work that you all have done. And especially the work of our faith leaders. So thank you. A few upcoming events. As you all know, October is Breast Cancer Awareness Month. In recognition of this, we'll be holding a special Facts and Faith session on Friday, September 30th from 3 to 4. Dr. Shepard, another Facts and Faith Friday seasoned saint, will be our guest speaker, and she'll be sharing some timely information about breast cancer. We'll pop information in the chat so you'll know and hear more about that. Keeping with the theme of breast cancer awareness, the Breast Cancer Foundation is sponsoring a breast cancer awareness lunch on October 3rd. More information will show up in the chat for that one. This is really important to me, and I think it's going to resonate with you. We all realize that medical institutions have not always done right with respect to marginalized communities. But I think VCU is doing its part to bring transparency and truth to the forefront. The VCU Office of Health Equity is hosting an inaugural History and Health Racial Equity Symposium on September 21st from 10 to 5. I, again, will give you the information or send it around afterwards, but we just want you to know that there'll be some ongoing conversations about racial equity and, you know, and what we could be doing better with the medical community. Just a quick couple comments about our future Facts and Faith Friday sessions. During our closed session on October 1st, again, our closed session is for our faith leaders, our associate ministers, and ministry leaders. We will continue our discussion on the toll of the pandemic on the mental health of our clergy. We'll also have a representative from the Virginia Breast Cancer Foundation and Dr. Jessica Young-Brown to talk about breast cancer and breast cancer awareness and making sure that our faith leaders have the information they need in order to provide resources and information to their congregants in the month of October. Finally, this is my final announcement. Our speaker on October 21st will be Dr. Gary Gibbons. He's the director of the National Heart, Lung, and Blood Institute. Dr. Gibbons will talk to us about cardiovascular disease, one of the C's that we've been talking about earlier today, and what we can do to help our patients, families, and congregants. Dr. Gibbons is an amazing speaker. We expect registration to be pretty robust for that event. So just be on the lookout to register. And we look forward to continuing this conversation about how we can combat cancer, COVID, and cardiovascular disease. Again, a huge thanks again to Dr. Singleton, Dr. Perry. Always a pleasure. You can come whenever you'd like to. We'd love to have you again. And unless Dr. Winn has any further thoughts, He's shaking his head like he's like,
No,
it's
thank you guys.
404. We'll close today's session with prayer by Dr. Jerome Ross.
Let us pause. Dear Lord, we thank you for the journey. Thank you for your traveling mercy that has brought us through seen and unseen dangers, the challenges even around us. Thank you for posting the angels along the way, dear Lord, that point us in the way that we should go. Thank you for those, dear Lord, that you have assigned to take care of souls and minds and hearts and bodies. Bless us as we gather, dear Lord, that our efforts may be fruitful in your sight. And we pray, God, that you'll keep us as only you can. Thank you for the moments together. Bind our hearts in that love, that we may hold each other close and treasure the moments that we share. Thank you for the privilege. We pray for your name's sake. Amen.
Come on, Pastor Ross.
Amen, Dr. Ross. That brought chills to me, sir. I really appreciate that prayer and covering. Thank you all. You have a great week, everyone.